يعني only the slide مش هيك؟ All right. طيب. Okay. Bismillah. So today we'll talk about hypertension, inshallah. And I'm hoping this will be an interactive session. I think it's a relative, pertinent topic for pediatrics, and something that you, depending on where you're at, you may or may not be seeing a lot of. So for today, inshallah, we'll talk about the blood pressure measurement technique, how we define, how do you define and diagnose hypertension, some basics of evaluation, and then talk about, again, some basics of management of hypertension in children. So we'll start, inshallah, with the technique. The reason I like to start with the technique is that you can't talk about anything with hypertension, the diagnosis, the evaluation, or the management, without first talking about the blood pressure measurement technique. قياس الضغط في الأطفال, it's one of the few situations that it really relies on the technique, and there is no objective method. It's very subjective. في كثير أشياء ممكن تأثر على الضغط وقراءة الضغط, the reading that you get, وبيعتمد عليها قرارات منها lab, evaluation, workup, and the management. So it's important to be familiar with the technique and the limitations of the technique. So I'll start with a question. I was not able to get the poll to get integrated into this presentation. So feel free to unmute yourself or send the answers by comment in the chat box. So Sadim is a 5-year-old, presents to the clinic for evaluation of a skin rash. The nurse informed you that his blood pressure is 115/75. This is an automatic measurement. The next best step is do nothing. This is normal. A. B, do nothing. His blood pressure is elevated due to anxiety. C, repeat the blood pressure using auscultation. D, refer the child to nephrology for evaluation. Or C or E, start him on amlodipine 0.1 mg per kg per day. Anyone care to share their opinion? Do you guys hear me?
I'm smart, so doctor.
Okay. يعني كثير خجل
في إجابة من الريزيدنت.
أنا عارف الزوم يعني بيعمل حواجز, بس برضه كويس الانتراكشن.
هي في إجابة من الريزيدنت على الشات.
Okay, ممتاز. So we have C, يعني حدا متطوع شجاع. C, repeat the blood pressure using auscultation. So yes, that is the correct question, and we'll talk about that in just a minute. So الأسلوبين طريقتين اللي بنقيس فيهم الضغط, as you may know, is auscultation and oscillation. ففي مهم الواحد يعرف الفرق بينهم عشان يعرف limitations of each one and why we prefer auscultation. So auscultation, the classic standard method of checking blood pressure, is you inflate the cuff until you no longer feel the radial pulse, and then you deflate the cuff. The first sound that you hear is called the first Kortikoff sound. That's the systolic blood pressure. And then when the sound disappears, that's called the fifth Kortikoff sound, and that is the diastolic blood pressure. So the first sound you hear is systolic, last sound that you hear is diastolic. With oscillation, it's a little bit different. The automatic machine inflates the cuff, and then it starts to deflate the cuff. And the machine actually measures vibrations that happen when you start deflating the cuff. So it does not listen to sounds, it measures vibrations that are generated by the turbulent blood flow. لما الدم بيمشي يبدأ with the deflation of the cuff, بيصير في vibrations, and the machine measures it. And then it takes the maximum vibration and considers that to be your mean arterial pressure. And from the map, it calculates the systolic blood pressure, and it calculates the diastolic blood pressure. So it's a different method of measuring the blood pressure. The reason why we say auscultation is better is because the standard, the normal numbers that we use were all developed using auscultation. And so that's why we say that we like to take we have to rely on auscultation. But in oscillation, the automatic method is more convenient. مش هيك؟ بالعيادة بالمستشفى أسهل إن الواحد يستخدم الoscillation It's faster to get a reading. And so if you have an abnormal reading by oscillation, you should confirm it with auscultation. So how should the blood pressure be measured? So there are a few things that are very important when you're measuring the blood pressure. One is the patient should be seated, quiet room, back supported, feet uncrossed. So if the patient's legs are crossed, that increases the blood pressure reading that you get. If it's busy, the patient's on what, playing a video game, على الجوال, بيحكي مع حدا, there have been studies that show this increases your blood pressure by a few points. Number two, it should be checked in the right arm. The right arm should be at the heart level, على مستوى القلب, uncovered. احنا كثير اوقات for convenience بتكون فوق التيشيرت او فوق البلوزه. And the arm should be supported. ما تكون معلقة, تكون sitting on a table أو على إيد الكرسي. And then the cuff size is very important. So ideally, بالظروف المثالية, you should measure the arm circumference. The bladder inside the cuff, هذا المنطقة اللي بتنتفخ داخل بنحط على اليد, the bladder should be in length 80% of the arm circumference. والwidth should be 40% of the arm circumference. هذا أحيانا صعب بالحياة, يعني بالأمور العملية ينعمل. So practically we say the cuff should fit comfortably on the arm, should not cross the elbow. المفروض ما تعدي الالبو, تكون يعني 2 سم أو 2 سم فوق الالبو, بحيث إذا الطفل ثنى ذراعه ما يكون في إشكالية. And the cuff should not pop off when you're inflating. If the cuff is too small, you get an artificially high reading. If the cuff is too big, you get an artificially low blood pressure reading. And then with auscultation, the bell should not be underneath the cuff. It should be, the cuff should be 2 to 3 centimeters above the antecubital fossa, and you can listen to the brachial artery at the elbow. So this is the standard, the classical one that we use. الأسلوب الثاني that we can use to diagnose hypertension is something called ambulatory blood pressure monitor. اللي هو جهاز بيقيس الضغط كل يعني 20 دقيقة أو نصف ساعة. بيلبسها المريض وبروح فيها على البيت. ما بعرف إذا هذا متوفر موجود عند يعني في فلسطين أو غير موجود, بس هو جهاز موجود يعني it's been used for almost 10 years or 15 years. المريض بروح بالجهاز and it automatically checks blood pressure. بيستخدمه فقط في الأطفال بعد ما يكون عمرهم 5 أو 6 سنوات عشان يتعاون مع الجهاز وما يشيل الجهاز, وبروح بالبيت وبينام في الجهاز. يعني هو صاحي وهو نايم 24 ساعة بالبيت, بيلبس الجهاز بعدين برجع لنا إياه. الميزة for the ABPM is we get readings at home when the child is in their normal circumstances and when they're sleeping. So if you have a high reading in the office but normal at home, it can help you diagnose white coat hypertension. And if you have normal blood pressure in the office but high at home, it can help you diagnose masked hypertension. So it's considered the gold standard. So this is what it looks like. جهاز بيلتبس على اليد, it connects, the cuff is on the arm, the device بيلبس ممكن زي شنطة أو زي حمالة, and the device is about the size of your cell phone, حجم الجوال, and they wear it with them. بينام فيها, بياكل فيها لمدة 24 ساعة وبعدين برجع الجهاز. هاي صورة الجهاز, شكل الجهاز أو أحد الأجهزة الموجودة في السوق. وهذا this is the kind of reading that we get from the 24-hour blood pressure reading. So الأبيض is when the patient said they were awake. المنطقة المظللة هذا, this is the patient when they were asleep. Well, these lines are the systolic and diastolic normal cut off for the patient. You can see here in the office, this patient had a blood pressure reading of 140/85. So this would be considered abnormal. But when they did the 24-hour blood pressure test, the reading was all green, they were all good. There are some standards, some measurements that we look at, but ما رح نتحدث عنهم كتير بهذه المحاضرة. But if the blood pressure looks normal on the 24-hour test, then we say this patient has white coat hypertension. والعكس صحيح, أحيانا بيجي مرضى بالذات اللي عندهم renal problems أو cardiac problems متعودين على العيادة, متعودين على المستشفى. بالمستشفى بيكون قياس الضغط طبيعي. So in this example, the blood pressure is 115/70. بس لما روح البيت وعمل 24-hour blood pressure, كانت القراءة كلهم قراءات أو أغلبهم بالليل وبالنهار مرتفعين. So this patient would have masked hypertension. So if you only rely on the reading in the blood in the office بالعيادة, you will miss these patients. They will be misdiagnosed. So it can masked hypertension or white coat hypertension. آخر شيء إنه at home measurement. So أحيانا we ask the patient to check their blood pressure at home. This is not something that should be used to diagnose hypertension, but it can be helpful in the management of hypertension. إذا في جهاز موجود بالسوق أو مشتروه من الصيدلية ممكن ياخذ الجهاز على البيت ويقيس الضغط بالبيت. المشكلة بالأطفال الصغار صعب تحصل جهاز عند الcuff is a small cuff to fit the child, but for older children, teenagers, ممكن if they're big enough, you might be able to use it. It's helpful to again not to diagnose, but only to manage hypertension. And then in the market, there are new devices that check the blood pressure on the wrist. بقيس الضغط على في الرسغ. They seem reliable. They seem reproducible. القراءة يعني you can get the same reading in a reproducible fashion, but they have not been validated in children, so we do not recommend using them. In the future, this is something that we might be using more of because it seems very convenient. بس لحد الآن ما استعملناهم بشكل مستمر. Okay. أي سؤال عن blood pressure measurement technique أو استفسار؟ All right.
دكتور بالنسبة للأمبيرتري بلاد بريشر ماشين هل بيستخدموها بس عيادات pediatric nephrologist ولا ممكن يعني is it expensive or كان بيستخدموها في الجنرال clinics general pediatric clinics؟
نعم فهذا it's a good question. احنا عندنا هون في مستشفانا احنا في النفرولوجي بيستخدموها. اغلب الناس في الاطفال بيكونوا النفرولوجيست هم اللي بيعملوا ال 24 hour blood pressure test. ما في مانع انه يعملها مثلا جنرال بيدياتريشن. المشكله انه بدك يعني خبره فيها والجهاز مكلف. في امريكا بكلف حوالي 2000 الى 3000 دولار الجهاز. فاذا بتعطيه لمريض والمريض ما برجع لك اياه هذا يعني خسر المستشفى او العياده 2000 ل 3000 دولار. فهذا من الاشكاليه يعني موجود باستمرار. ما بعرف اذا الجهاز موجود او يستعملوه في فلسطين.
ما مر علي والله دكتور بس مش عارفه يعني احنا عندنا نفرولوجيست دكتور سامي ممكن نساله عنه بس هو مش موجود.
هو موجود يعني it's considered based on the new guidelines. آخر guidelines بال AAP. This is the gold standard to diagnose hypertension. فالمفروض حتى أي طفل شاكين عنده hypertension نعمل له ABPM. المشكلة الأساسية يعني حتى في أمريكا مشكلة فأكيد في بلادنا رح تكون أصعب إنه how to get the device, how to do the test. سهل جدا المريض ياخذ الجهاز وما يعمل الفحص أو يعمل الفحص وما يرجع الجهاز أو إذا خربوا بله يعني كل هذه الأمور ممكن تخرب الجهاز it can be challenging. بس بالادلتس في الأوقات الانترنال ميديسن they will do it لأنه they have more patients with hypertension. فانترنست will do it. في البيدياتريكس على علمي ما في general pediatrician يعني بيعملها. I don't think they're comfortable doing it. ما بيكون مرتاح فيها.
تمام. شكرا دكتور.
All right, so we'll talk about the definition and diagnosis of hypertension. So the next question we have the repeat blood pressure for Salim 105/60. You have an enthusiastic medical student. Is this a normal blood pressure or not? So you respond A, blood pressure readings are unreliable in children. B, blood pressure in children should be lower than the adult number of 120/80. And this is lower than 120/80, so this is normal. C, normal blood pressure is less than 90th percentile for age, gender, and height. Or D, normal blood pressure is less than the 95th percentile for age, gender, and height. حدا بحب يشارك أو بالchat box خبروني شو رأيكم. A, B, C, or D. So برضه C, yes. لما كتبت السؤال ما انتبهت إنه both answers were C, بس yes. مش دائما أنه C صح ولكن in this situation, yes. Normal blood pressure is less than the 90th percentile for age, gender, and height. This is based on the American Academy of Pediatric Guidelines. If you're not familiar with this, I highly recommend it. This was published in 2017. وفي European guidelines published in 2016. في كثير من الأمور متشابهة بينهم. في بعض الاختلافات أو الاختلافات الأساسية هي في الثريشولدز البلد بريشر threshold اللي بيستخدموها. في next slide, this is the American Academy of Pediatrics. In the new guidelines, if the child is 13 years or above, we use the adult cutoff, which I will talk about in 1 minute. But if you're less than 13 years of age, between 1 and 13, then a normal blood pressure is less than the 90th percentile, both systolic and diastolic. Elevated blood pressure is between the 90th and the 95th percentile. It's stage 1 hypertension between 95th and 95th plus 12. And stage 2 is greater than or equal to the 95th plus 12. So these are the classifications or stages of hypertension based on the AAP guidelines. And in children that are 13 years and older, both males and females, we use the adult cutoff. And the guidelines for the adults have also changed in 2017. So less than 120/80 يعتبر normal, 120 to 129 for systolic, and less than 80 is elevated. If the blood pressure been in 130, 140 for for systolic and 80 to 90 for diastolic, this is considered stage 1. وأكثر من 140/90 يعتبر stage 2 hypertension. So I think most of our doctors and residents are familiar with the blood pressure reference chart. So this depends on the age, the patient's age, gender, and height. And the new guidelines, they updated the cutoff, the blood pressure cutoff. الفرق بينهم وبين guidelines اللي كانت قبلهم, and they removed all patients that were obese or overweight from the normal population. وبالتالي all the numbers, the cutoff went down by a few millimeters, and obesity is a confounding factor for hypertension. So this is an example of what you can use. There are online calculators that you can also use if you want to, instead of having to pull this up. And then this is one from the AAP guidelines. They have a nice table. I highly recommend this, printing this or having this in your pocket or بالعيادة. This is just kind of a quick cut-off value. If the blood pressure is higher than these numbers, then you should be screening the patient for hypertension. So this is just kind of a quick way, and you can see if they're 13 years and above, we use the adult numbers. So the diagnosis of hypertension, just to recap, if the blood pressure is greater than 95th percentile, or greater than or equal to 130/80, and it should be obtained on at least 3 separate visits. So this is the pathway of of the best way to check the blood pressure. So if the patient has an elevated blood pressure, more than the 90th percentile, بنفس العيادة بنفس الزيارة, the recommendation is check the blood pressure twice and then get the average of these readings. If you can use oscillometry or you can use auscultation. If you use oscillometry, make sure you get auscultation to confirm that the blood pressure is elevated. الآن based on your reading, it dictates what you'll do. وراح نتكلم عنها كمان شوي, نتحدث شوي. But in general, if the blood pressure is elevated, the AAP recommends that we do lifestyle counseling. We check the blood pressure in 6 months. In a stage 1 hypertension, lifestyle counseling, we check the blood pressure in a few weeks, 1 to 2 weeks. In a stage 2 hypertension, you should start treatment and refer them for specialty care. إذا كان very high or symptomatic, طبعا هذا المريض المفروض يروح الطوارئ. This is not something you will manage in clinic. So with hypertension, new high score is obviously not a good thing. Any questions about the definition or diagnosis of hypertension?
بس أنا عندي سؤال في تعريف الهايبرتنشن. مكتوب إنه سيستوليك أند دايستوليك يكونوا أعلى من 95 برسنتايل. في بعض مرضى بيكون عندهم القراءات فاريبل، يعني لو نطلع على السيستوليك بتكون أعلى من 95 برسنتايل ولكن الدايستوليك أقل أو العكس.
نعم، فملاحظتك ممتازة. التعريف خطأ، هي systolic or diastolic. يعني you take بالقراءة بغض النظر you take the worst reading. فإذا كان السيستوليك دخل بستيج 1 والدايستوليك elevated then تعتبر المريض stage 1. إذا كان أحد السيستوليك مثلا elevated والثاني الدايستوليك normal blood pressure بتعتبر المريض elevated. فأنت regardless of the category أي جروب بتحطه تأخذ أسوأ واحد فيهم. يعني the highest reading is the one you consider for the patient. Does that make sense?
Yes, okay.
ممتاز. فهي it's the worst one that you get. الآن يعني قبل ما تيجي هذه الجايد لاينز كنا أحيانا بعض البيدياتريك كات أوف أعلى من الأدلت كات أوف. بغض النظر عن الظرف pediatric cutoff should not be higher than the adult cutoff. فإذا blood pressure تاع المريض في أي حالة أكثر من 130 على 80, you know this is an elevated blood pressure. But it should be, you should take the highest of the systolic or diastolic, and consider that to be the stage of hypertension. طبعا after you get more than one reading for the patient. Right. Any other questions? All right, so evaluation of children with hypertension. So we're at a point where we check the blood pressure. We know the blood pressure is high. And so what do you do for the patient? So in children, the goal of evaluation, we have two main goals. One is we want to rule out secondary causes of hypertension, because secondary hypertension is more common in children than adults. And two, we want to assess for end organ damage. So we want to see if the patient has end organ damage and things that we need to modify or work on. So history and physical exam are extremely helpful to guide your workup and what to do. And that's why getting a good history from the patient is very important. This is a slide that just summarizes the percentage of, or the prevalence of primary versus secondary. You can see in infants, it's almost always secondary hypertension. So any child who's less than 1 year, you should think and look for a secondary cause of hypertension. Secondary hypertension is still the most common cause of hypertension compared to primary. بالأطفال school-age children, لغاية 8 years, 10 years, this is secondary hypertension is the most common. With teenagers, they tend to have more primary hypertension. طبعا هذا الكلام, this is coming more from Western data, بالذات يعني بأوروبا وبأمريكا, لأن الأوبيسيتي عم بتزيد بشكل كبير. بتوقع في بلادنا it's still not as high, but I think we're heading towards that. الناس عم بتغير الدايت تبعها, بتاكل أكل في يعني طبيعة الأكل, والسمنة عم بتزيد في الأطفال. So that also is probably going to change. It may not be this high, but the general change is there's more common, secondary hypertension is more common in children. With teenagers, you probably have the same or a little bit more primary hypertension. رح نتحدث شوي in a few slides about the causes of secondary hypertension. So primary hypertension, the obese children have 2 to 4 times increased risk of hypertension. عادة, the typical presentation is you have an overweight or obese child. They are usually more than 6 years old, and they have a positive family history of hypertension. This is kind of the classical presentation that you will see. So again, in a younger child, it's unlikely to be primary hypertension. If they're not overweight or obese, it's unlikely, or they typically have a positive family history of hypertension. With this slide, you can see that in patients, 70 patients that have primary hypertension, the majority of them have a higher percentile of the BMI, which is not surprising. What about secondary hypertension? So this is a summary slide from Nelson Pediatrics about the secondary causes. There's a long list of things that can cause secondary hypertension. The American Academy of the AAP guidelines, it's I think 2 pages long. It's beyond the scope of this talk, but it's good when you're approaching or thinking about secondary hypertension, think about the different systems. The most common ones are renal, endocrine, neurologic, vascular, other causes, and then medications, which is going to be on the second slide. And so renal causes, very common in children, خصوصا the younger children, acute kidney injury, chronic kidney disease, glomerulonephritis, patients that have renal scarring, if they have a history of pyelonephritis or recurrent UTI, tend to have secondary hypertension. So these are the patients that you want to look for you want to make sure that you are not missing a renal cause of secondary hypertension. Endocrine, also a long list of things that can do this. Thyroid disease is one of them. Here they list only hyperthyroidism, but I want you to know that hyper and hypothyroidism are associated with high blood pressure. So both both hyper and hypothyroidism can cause elevated blood pressure. Any condition that leads to increased cortisol, like hyperaldosteronism, hypercortisolism, lead to that. So whether it's they're taking medications or they have an underlying medical condition that can lead to hypertension. وcatechol-secreting tumors, بالامتحانات الكل بيحب هذا السؤال. Pheochromocytoma, يعني أو neuroblastoma, very common question. Realistically, they are not as common. ما بنشوفهم بالواقع as much as we see some of the other causes. But if you have a classic history that fits, think about pheochromocytoma. Or if a child is the right age, think about neuroblastoma. Neurologic, the one that you don't want to miss, increased intracranial pressure. The المريض عنده some abscess, intracranial abscess, tumor, or something else. Increased sympathetic activity can also cause hypertension. or dysautonomia. So you might see this in a patient who has intracranial bleeding, or some patients with cerebral palsy, CP. They can have dysautonomia that causes hypertension. Renovascular causes, the two most common ones, coarctation of the aorta. Coarctation is something that will usually be caught in the first year of life, but sometimes children make it, they become older and it doesn't get found until they're at an older age. Well, the other second most common cause is renal artery stenosis. And then other causes are obstructive sleep apnea and medications. Out of this long list, I would say the things that we probably most commonly see are coarctation of the aorta, renal artery stenosis, and kidney conditions. So we want to keep those in mind when you're thinking about a patient with hypertension. بالإضافة للمedications. So medications, بالمرضى اللي بالمستشفى, إذا مريض منوم, they have other medical problems, think about medications. هذا التable again from the American Academy of Pediatrics. فممكن يكون هنا what's over the counter بأمريكا ما يكون over the counter بفلسطين أو ببلدان أخرى. But the common medications اللي هي في nasal decongestant, pseudoephedrine بيستخدموا المرضى اللي برشح أو مزكم بجوز حدا يكتب لي إياه. Pseudoephedrine causes hypertension. Caffeine, فعندك newborn babies if they're on caffeine because of apnea. NSAIDs can cause hypertension. And then some بعض الأعشاب ممكن والشيء المشهور عندنا عرق السوس ممكن يعمل hypertension. فإذا حدا يعني الناس بالزمانات بتحبها، إذا حدا بحب عرق سوس كويس تسأل أو مهم تسأل عنه بالذات إذا فترة رمضان يعني تأكد ما بشربش عرق سوس. Some medications that need a prescription. ADHD medication, stimulants for ADHD, steroids are very common, most common ones. وهذا طبعا illicit drugs. Hopefully you don't have a child that is using amphetamine or cocaine. يعني في مشكلة أكبر if they're using that. All right, so what do we usually get for patients? So in general, any patient that comes with hypertension, you as we said, you're going to check with auscultation. If you confirm the blood pressure is high with auscultation, you're going to check at 3 separate visits. And if you confirm they have hypertension, then at that stage, you're going to do some evaluation for the patient. So in all patients, we recommend getting chemistry panel, check at their serum electrolytes, check the kidney function. We do a urinalysis. And then most of the time, they will do a lipid profile and renal ultrasound. The lipid profile is recommended to look for risk factors for atherosclerosis. So in younger children, you might not need to send that. A renal ultrasound is to look for structural abnormality, يعني إذا في شيء abnormal بالkidney. ممكن وتطلب معها Doppler to check for renal artery stenosis. Kidney function will tell you if the patient has acute kidney injury, chronic kidney disease. Chemistry panel will help you if the patient has potassium abnormalities that can come with hyperaldosteronism, for example, and other conditions. But the urinalysis is also helpful if you are looking for protein and blood in the urine. بالمرضى اللي عندهم glomerulonephritis. If they are obese, make sure you check their A1C and AST and ALT to look for fatty liver disease. And then if your history and physical exam suggests this, you can check their thyroid function. You might need a sleep study. So patients that have obstructive sleep apnea can have hypertension, and you might need a CBC, which shows an elevated hemoglobin with OSA. So what about echo? So the echo is helpful to assess for left ventricular damage. عادة نعملها we do evaluation to look for a secondary cause of hypertension, or we look for end organ damage. So the echo helps us with end organ damage. And you want to look for structural abnormalities or functional abnormalities. So we look and evaluate for left ventricular hypertension. And we can look for the ejection fraction for the function. I listed the cutoffs here. Again, if you're not typically managing these patients, you don't have to memorize this, but I want you to be aware that there are normal numbers that we use to determine if the patient has LVH or does not have LVH. Or if the ejection fraction is less than 53, we consider that to be abnormal. An echo can have also another benefit. If you're not sure, شاك بالcoarctation of the aorta, it helps to have the echocardiography. All right. So when should you do an echo? We should do that if you're starting the patient on medications. should be repeated every 6 to 12 months if the echo is abnormal, and then or the patient has persistent hypertension. We do not recommend doing an EKG to diagnose LVH, left ventricular hypertrophy. It has a low sensitivity. That's why it's not recommended routinely for patients. What about imaging? Now, ultrasound should be obtained in younger children, or if they have an abnormal UA or creatinine, checking and if there's something renal going on. In general, we tend to get it. It's easy. It's not invasive. We tend to get it for most children. With Doppler ultrasound, Bifida, it helps to make sure the patient does not have renal artery stenosis. Just know that Doppler has low sensitivity and good specificity. For sensitivity, تقريبا 50%. So you might miss 50% of patients with renal artery stenosis. If it's abnormal, it gives you the diagnosis. If the Doppler, the flow is accelerated, you know this patient has renal artery stenosis. But if it's normal, it does not rule out renal artery stenosis. And if you suspect it, then we do CT angiography, or you can do an MRA to diagnose renal artery stenosis. And then sometimes in some patients, we'll actually do angiography, where the cardiologist or interventional radiologist will go in, inject dye, and take a look to see if there's renal artery stenosis. But this is only done if you really suspect renal artery stenosis. Well, this is an example of a CT angio, where you can see this is the aorta, and you can see that the renal artery has significant stenosis on this side. It's less easier to see on this side, but very obvious on this kidney, on the CT scan. All right. Any questions about the evaluation of patients with hypertension, or the testing, or the causes of hypertension? All right, good. And then the last part, we'll talk about the management of hypertension. So the target blood pressure, what blood pressure do you want for the patients? Well, the normal blood pressure should be less than the 90th percentile. So that should be the goal for the AAP guidelines. The goal is to bring down the blood pressure to less than the 90th percentile, which is less than 130/80 in a can, more than or equal to 13 years old. This is for your general healthy children. Then this is the goal that we aim for. If the mariid under chronic kidney disease, we actually target a lower blood pressure. وأحيانا بالdiabetes, the AAP guidelines do not comment on diabetes, but the European guidelines that I mentioned also suggest targeting a lower blood pressure in patients that have diabetes. Then في هذول المرضى, we know they will have kidney disease, and we know that the kidney disease gets worse if they have uncontrolled hypertension. لذلك controlling their blood pressure is very important. Chronic kidney disease, there was actually a randomized clinical trial that showed patients that had a blood pressure at the 50th percentile had less progression to end-stage renal disease. So it's one way to slow down progression to renal disease, and it's something that can be done relatively simply. So how do we manage hypertension? There are two main things that we can do. One is we do lifestyle modifications, and two, pharmacological therapy. So who should get lifestyle modification? Patients that have elevated blood pressure or asymptomatic hypertension without end organ damage. So these are the patients that only have elevated category, or they have stage 1 hypertension and no evidence of end organ damage. So if the patient, if you've done an echo, the echo is normal, they don't have any vision problems or vision changes, it's okay to do lifestyle modification. But you need to start medications in patients that have symptomatic hypertension. If they have severe headaches, they have changes in their vision, they had a stroke. So if they have symptomatic hypertension, end organ damage, stage 2 hypertension, or chronic kidney disease or diabetes, that is an indication to start the patient on medication. And حتى المرضى where you start pharmacological therapy, you should still do lifestyle modification. So lifestyle modification is done for all patients. So this is just a reminder that I mentioned earlier. We target the blood pressure. If the blood pressure is more than the 90th percentile, you will confirm it. This just kind of reminds you that if it's elevated, you can see them back in a few months and check their blood pressure. If it's stage 1 or stage 2, you need to act more quickly. So stage 1, we start with counseling and then have them come back for follow-up in 1 or 2 weeks. If stage 2, you should start treatment in clinic and start the evaluation in clinic refer them to be seen. Here, the recommendation is within a week, but it depends on where you are and how easy it is to get an appointment. And if it's severe hypertension, again, this is a patient going to the emergency room. So lifestyle modifications. There's a long list of things that seem to decrease the blood pressure. بس بشكل عملي بشكل واقعي للمريض يعني يستوعب عليك, I recommend these three things. Diet changes, physical activity, and weight loss. Diet changes have been shown to decrease blood pressure with adult studies, not so many in children, but it looks like it decreases the systolic blood pressure by about 10 millimeters. So it's a significant effect on that. Physical activity and weight loss decreases the systolic blood pressure on average around 5 to 6 millimeters of mercury. So they can have an important impact on the blood pressure in children as well. So there have been some studies for that. بالنسبة للdiet, في something called the DASH diet. مشهورا بأمريكا, they recommend it. But the components of the DASH diet اللي هي you want to increase fruits, vegetables, الحبوب, grains, nuts, واللحوم اللي هي ما فيها دهون كثير مثل السمك واللحمة الحمراء. قلل من السكر, من الأملاح, الصوديوم, قلل من الدهنيات. يعني بين قوسين هي يعني بدك غذاء صحي اللي هي الناس كثير من الناس بتعرفه, بس بيحتاج التأكيد عليه. الأكل الدهن, الأكل اللي فيه سكر كثير أو فيها أملاح عالية ننصح بتجنبه. الأكل اللي فيها خضار, فواكه, لحوم حمراء, أسماك تعتبر من المأكولات الصحية, وهذا اللي ننصح فيه المرضى. الآن على التطبيق العملي بيحتاج هذا يعني جلسات, يعني ليس جلسة واحدة لكن جلسات انك تجلس مع المريض وتساعدهم. طبيعة الأكل اللي عندنا فيها يعني نحب اللحم الدهنة, نحب اللية في الأكل, ناكل يعني الشيف المقالي, يعني الكنافة. هذا طبيعة الأكل في بلادنا فيها يعني كثير من الجوانب الغير صحية, بالإضافة للجوانب الموجودة المتوفرة صحيا بس بيحتاج الواحد يأكل عليها. فالخضار والفواكه موجودة بطبيعة الأكل اللي بناكله, فكويس التركيز عليها وتجنب الأملاح من الأكل. Sodium يعني has been shown consistently to increase blood pressure in adults and children. The more you take, the higher the blood pressure. And this is just a slide that shows DASH diet بالأطفال بالpediatrics في بنات كان عمرهم 10 years and above. They followed, they had them fill a questionnaire with their diet, but they showed that the teenagers that took a healthy, that took more servings of fruits, vegetables, and dairy products, اللي هي المشتقات الأجبان والألبان, had lower blood pressure on average than the ones that took less. So this is just an example of a study in pediatrics. And this is on sodium intake. So this is a group, they looked at 6,000 children, again, questionnaire style, 8 to 18 years old. وجدوا on average, بس سألوهم شو بتاكلوا بالبيت, and they had their blood pressures measured. And they found on average, here in the United States, their average intake of sodium was 3,400 milligrams. The recommendation is to be less than 2,000, ideally less than 1,500. So on average, children here are eating 1.5 to 2 times more sodium than the recommended intake allowance. And in this group, you can see on the x-axis, this is the usual intake of sodium. So the more you go to the right, the higher sodium intake, and this is their systolic blood pressure. And you can see that the blood pressure increases as the sodium intake increases. It's even more dramatic if you compare non-overweight to the obese and overweight children. They tend to have significantly higher blood pressure. With this study, they found that كل ما قللت الsodium intake by 1,000 milligrams per day, قلل blood pressure, systolic blood pressure by 1 millimeter per day. So it also impacts your systolic and diastolic blood pressure. So it's important to think about that. المشكلة الصوديوم إنه بيخطر ببالنا, وهذا من الأمور المهم نبدأ فيها اللي هي نتجنب الأكلات المالحة, فهذا شيء كويس. عندنا الجبنة النابلسية طبعا يعني من الأمثلة الطيبة لذيذة بس فيها ملح عالي جدا. المنسف فيها ملح, ففي الأمور المالحة واضح إن الواحد لازم يتجنبها. بس أيضا المأكولات المحفوظة عادة فيها كمية صوديوم عالية، وإن كان طعمها مش بالضرورة يكون مالح. فالصوديوم يستخدم كمادة حافظة ممتازة في الأكل. فالأكلات مثلا زي المرتديلا عادة فيها لحمة فيها كمية صوديوم عالية. الأشياء الخضار أو الفواكه المعلبات عادة فيها كمية صوديوم عالية لأنها تستعمل كمادة حافظة. ولذلك بجوز ما يخطر ببال المريض أو أهل المريض أن احنا بناكل صوديوم، بس إذا ما يعني بيستهلك مأكولات فيها مواد حافظة كثير عادة بتكون فيها كمية الصوديوم عالية. حتى لدرجة المشروبات الغازية عادة بيكون فيها صوديوم، الكوكا كولا والمشروبات الغازية غيرها فيها كمية صوديوم عالية كمادة حافظة. لذلك لا ننصح بالملح للأطفال اللي عندهم hypertension. طيب, what about physical activity? So we recommend moderate to physical activity 3 to 5 days per week, 30 to 60 minutes per session. فالmoderate to physical activity, vigorous physical activity اللي هي يعتبر شيء بيزيد النبض. عادة we say 20 to 30 beats per minute بيزيد الهارت ريت and 30 to 60 minutes per session. بيعتمد على الظروف الطفل والبيئة الموجود فيها may or may not be easy to do. بس أشياء مثل لعب كرة القدم أو الأطفال الأصغر سنا بيلعب على المراجيح والسحاسير، الحركة والنشاط هذا كويس. والأطفال الأكبر إذا بيركب بسكليت أو دراجة بيجري في الحارة، إذا في سباحة متوفر، شوف حسب الظروف المتوفر فيها، بس تكون حركة فيها يعني شيء فيها حركة وزيادة النبض وليس فقط رياضة في المكان. مثلا زي رفع الأثقال أو غيرها، المصارعة هذه يعني لا يعني الفائدة تاعتها أقل من الأمور اللي فيها حركة ونشاط أكبر. فيعني there have been some studies that show that physical activity in adults, this has been shown consistently. A few studies in children, like this one, they randomized 44 children, حطوهم جروبين، جروبين من الأطفال عندهم سمنة. الجروب الأول عمل ساعة 3 مرات بالأسبوع، والجروب الثاني ما عمل أي شيء، ما عمل رياضة، استمر على ظروفه. They found that the blood pressure had significantly decreased, systolic, diastolic, and 24-hour blood pressure decreased for these patients. So physical activity بالأطفال، الحركة والنشاط أيضا بيساعد في تقليل الضغط. آخر جروب اللي هي كويس اللي هي weight loss إذا كان الطفل عنده سمنة. فهذا إذا الطفل وزنه طبيعي أو معقول بالنسبة لعمره فهذا شيء كويس. نعتبر ال BMI أقل من اللي هي 85th percentile. If the blood pressure is normal, if the weight is normal, we don't worry about weight loss. بس إذا كان الطفل عنده سمنة أو شاك إنه عنده primary hypertension, then we work on weight loss as well by reducing caloric intake and increasing physical activity. بالadults برضو each 1 kilo weight loss looks like the blood pressure decreases by approximately 1 millimeter mercury. طبعا بهدول الأطفال sometimes you need multidisciplinary approach. تشوف endocrinologist إذا عندهم diabetes أو high blood sugar، يحتاجوا يعني يشوف أخصائي التغذية حتى نتكلم عن الأمور الغذائية اللي ممكن تكون يعني هي الأفضل لهم. وفي أساليب أخرى ممكن تساعد في يعني تخسيس الوزن مثل الأدوية، أو أحيانا بيحتاج إذا سمنة شديدة جدا يجوز يحتاج عملية قص معدة أو غيرها في الأطفال الأكبر سنا وعندهم سمنة يعني مفرطة جدا. طيب آخر شيء عندنا اللي هي الأدوية. So how do we approach pharmacotherapy? So في أمور أساسية لازم نفكر فيها، أو يعني قواعد عامة نستعملها لما نبدأ الأدوية. أولاً نبدأ يعني we want to start a medication that gives us the effect we want with the least side effects for the patient. بتعرفوا كثير من الأهل بالذات في الأطفال بيخاف من الأدوية، بيتجنب الأدوية، عندهم رهبة من الأدوية. فأنت بدك تحاول يعني تتجنب يكون دواء له أعراض جانبية ممكن أيضاً تزيد من هذا الخوف أو الرهبة. عادة نبدأ بأقل جرعة في الدواء، أقل جرعة العلاجية، وبنزيد الجرعة تدريجياً كل أسبوعين ل4 أسابيع حتى نصل حتى ينزل الضغط للجول والتارجت المطلوب لهذا المريض. وإذا ما تحسن وصلت لأعلى جرعة في الدواء بنضيف دواء ثاني. إذا نبدأ نفس الشيء جرعة قليلة نزيد الجرعة كل أسبوعين أو 3 أو 4 لحد ما نصل الماكسيمم دوز. ما تحسن الضغط نزيد جرعة دواء ثالث ودواء رابع وهكذا حتى تصل حتى يعني يصل الضغط الدم للرقم المطلوب في المريض. So which class do we start? So in terms of classes ما في any evidence-based recommendation. بس بشكل عام we start with a medication class that will target the underlying etiology. So إذا عندك مريض عنده مشكلة معينة أو مرض معين أو secondary hypertension, there are some drug classes that are better if the medication has a potential added benefit, then we use that. And you want to, or if you want to avoid specific side effects, you might not use that medication class. وراح أعطيكم بعض الأمثلة في السلايدات القادمة. طيب, what are the groups of medications? إذا ما أخذت من المedication الأدوية إلا هذا السلايد, I think يعني this will be very helpful. فهذا يعني يمكن أهم واحد بالmedications. And blood pressure classes تعتبر 4 main ones اللي هي A, B, C, D. فالA اللي هي ACEs or ARBs, ممكن نضيف لهم الألفا agonist. الB beta blockers, C calcium channel blockers, and D is diuretics. فإذا عندك مريض عملت الفحوصات, you have high blood pressure, you have confirmed the blood pressure is high, and you are ready to start medications, you have to choose one of these 4 classes. And when you choose this, the simple rules are, which one of this classes is going to work best for the patient? Is there a side effect or contraindication to this class? Is there an added benefit that I can use? And just use A, B, C, D. And so you'll start with one class. So for example, if you start with A and you start with you choose a medication, start with a low dose, you go up. It doesn't work, then you have to use a second class, and then the third class and a 4th class. But these are the classes that you think about for the medications. I'm going to pause here and make sure that this makes sense, because I think this is very important. So does this slide and approach to medications make sense? Okay, done. So the last few slides will be the actual medications and some of their side effects. So ACEs and ARBs, مثل ACEs عادة الميديكيشن آخره بيكون بريل, enalapril, lisinopril. فإذا if you see that تعرف إنه هذا ACE or ARB, losartan أو valsartan, هذول يعني common medications that are ARBs. حكينا إذا الميديكيشن له فائدة معينة, it's good to use it if you target certain mechanism. فالمريض اللي عنده renal artery stenosis, إذا كانت unilateral, this is an excellent medication to use because they have high renin secretion, and a ACE inhibitor or ARB is perfect for this patient. You should not use ACEs or ARBs with bilateral renal artery stenosis because that can lead to renal failure, shutdown of the kidneys. Another benefit is the ACEs and ARBs have anti-proteinuric effect. فالمرضى اللي عندهم chronic kidney disease أو diabetic nephropathy عادة بيكون عندهم proteinuria, وهذا proteinuria leads to progression of the kidney disease, and therefore ACEs and ARBs are perfect medications to use. فإذا عندك مريض عنده hypertension, then this is a good, excellent medication to use for these patients. Main side effect, you can have cough, headache, and then it less common but severe, it can lead to AKI and hyperkalemia. So we monitor the kidney function potassium for these patients on the medication. It is contraindicated if the patient has angioedema, contraindicated in pregnancy. Again, hopefully not something you see in children, but in someone, and it's absolute, it should be stopped if you have an older patient that's on this medication. It is toxic to the fetus kidney and should be stopped immediately. Beta blockers, في non-selective وفي البيتا 1 selective, non-selective زي labetalol, beta 1 selective زي atenolol. A very good mechanism is we use them with in patients with pheochromocytoma, but this is only used after you have alpha blockade. They should not be the medication you start with. That can be dangerous and should not be done. ممكن يكون فائدة للمريض عنده anxiety or elevated heart rate. Because of the effect on the heart rate, it might be a good medication to start with. Main side effects in bradycardia and impaired glucose tolerance, contraindicated in patients with asthma, and can be used in caution in patients with heart failure. عادة we talk to the cardiologist before starting a beta blocker. If we're going to start it, then the beta blockers are not recommended as a first line. They tend they from the different classes, they have the least impact on the blood pressure. So we avoid using them as first line. Calcium channel blockers, هذول يعني نعتبر الناس يعني طيبين, لا إلهم ولا عليهم. They don't have a good indication for absolute indication, but also they don't have an absolute contraindication. So it's a good medication as a first line. عادة the side effects, main side effects, some flushing, some edema for the patient. They can have peripheral edema. غالبا this is not severe enough to stop the medication. Most patients will take it and not have issues. And again, it's typically a nice medication to start with for patients that have hypertension and you don't have a specific mechanism or underlying cause to treat. And then last but not least is diuretics. The two main classes اللي هي loop diuretics with thiazides. So loop زي furosemide, bumetanide, thiazides like chlorothiazide, hydrochlorothiazide are the ones that we typically use. عادة loop diuretics we do not use them as a first line agent. ممكن يفيدك أحيانا إذا المريض بالمستشفى وعنده edema for other causes مثلا liver failure or heart failure. The patient has edema. Loop diuretics is a good option in that situation, but عادة it's not a medication that we start outpatient. Thiazides are actually favorable as a second line agent. بالذات إذا المريض عنده primary hypertension. They tend تحكي معاهم طبيعة أكله كثير بياكل ملح كثير. Thiazide diuretics يعني خيار كويس. Side effects mainly on electrolytes. They can cause hypokalemia. Thiazides increase the uric acid. طبعا if the patient is anuric, this is not going to be beneficial. But then the last slide is when should I stop therapy? There's no evidence-based recommendations. عادة we will follow the patients every 3 to 6 months when they're on a stable dose. And we usually decrease the medication if the blood pressure is low or low normal. فإذا كان عندك ضغط المريض كويس or the patient has symptoms of hypertension, in that situation we start weaning the medication. If not, then we continue to follow and monitor the blood pressure to see. So there's no clear guidelines on how long the patient needs to be on it. If you have an underlying condition, it depends on what that condition is. If you have primary hypertension, it depends on modification of lifestyle. So in summary, treatment of hypertension is recommended based on indirect evidence. We should, do lifestyle modifications for all patients. We recommend pharmacotherapy in patients that have symptomatic hypertension, evidence of end organ damage, and patients with chronic kidney disease. And the choice of medication and follow-up should be tailored to your patients. And that is all. So I'm happy to take any questions. أي سؤال استفسار عن الهايبرتنشن.
شكرا دكتور عبد الله. إذا بتسمح لي في سؤال اللي هو بيتعلق بال is there is any recommendation for regular screening for children who are not at risk for hypertension? Do we have to do a regular screen for blood pressure management في outpatient clinic for these children?
نعم، فهذا بالنسبة للمرضى اللي ما عندهم أي مشاكل، ما عندهم مشاكل صحية healthy children. recommendation American Academy of Pediatrics recommends routine screening for children when they turn 3 years old بشكل سنوي. يعني مرة بالسنة نشوف البلد بريشر تبعهم، نقيس الضغط بالعيادة اللي هي بسموها well child visit، زيارة عادية جاي ياخذ المطاعيم، نطمن على النمو، أموره الأخرى كويسة. فإذا ما عنده أي مشاكل، ما في أي مشاكل صحية at least once a year بعد ما يصير 3 سنوات. قبل ال3 سنوات صعب شوي، مش كل الناس عندهم الجهاز المطلوب، والطفل طبعا صعب يتعاون بيتحرك كثير فبتكون أصعب. قبل ال3 سنوات عادة we recommend المريض عنده أو الطفل عنده مشاكل أخرى، مثلا preemie babies should be getting the blood pressure checked at every clinic visit. المرضى اللي عندهم obesity they should be checked at every clinic visit. المرضى اللي عندهم kidney disease، المرضى اللي عندهم diabetes. So if they have risk factors for hypertension or kidney disease that is worsened by hypertension, they should be getting blood pressure checked at every clinic visit. كل زيارة مفروض نتأكد إنه البلد بريشر تبعهم كويس وطبيعي. مش شرط يكون عند النفرولوجيست. فإذا المريض الدايابيتك بيروح على عيادة الاندوكرين مفروض يتابع بالاندوكرين وهكذا. بس الروتين سكرينينج فقط في المرضى اللي هي يعني بشكل سنوي بعد ما يصير الطفل 3 سنوات.
أنا بدي أشكرك دكتور عبد الله، وأنا كمان بحب أشكر الحضور اليوم. محاضرة كانت رائعة. هاي المرة كان معنا حضور مش بس من مستشفى النجاح سواء مقيمين وأخصائيين، بل كان في حضور كويس من عدة مستشفيات في فلسطين حكومية وخاصة. فشكرا لك وشكرا لجميع الحضور.
شكرا لكم جميعا. إذا في أي سؤال أو استفسار يعني أرجوكم، أنا راح أكتب الإيميل تبعي بالشات بوكس، يعني رجاء ما حدا يتردد يبعث لي إيميل أو سؤال أو استفسار. وأنا إن شاء الله يعني في زيارة الوطن يعني الشهر القادم، فيعني إذا صار مجال يعني قد نلتقي بعض الأطباء الطيبين هناك إن شاء الله.
دكتورة ميسة.
تفضل دكتور ماجد. دكتور ماجد وجيش أخصائي الأطفال في مستشفى الاتحاد والمدير الطبي.
والله أنا حبيت أشكر الدكتور عبد الله، يعني الدكتور عبد الله الوالد تبعه هو أستاذنا وحبيبنا، وإحنا بننتظره في الزيارة الجاي وممكن نعمل له محاضرة. والدكتور محمد هليل بلشنا نجمع له حالات، وبدي أحكي لميسة إذا في حالات الدكتور محمد حابب يشوفهم مجانا لوجه الله عندنا بالأم كلينيك أو بالاتحاد، يعني هذول إذا في حدا من الإخوان سامع يعني يتواصل معي نسجل اسمه للدكتور محمد هليل اللي هو والده للدكتور عبد الله. طبعا فرخ البط عوام. أنا للأسف جيت مش في أول المحاضرة لأني كنت في المستشفى وانضميت لكم بعد النص الأول، بس بنحب نشكرك دكتور عبد الله على هاي المحاضرة الرائعة، وإن شاء الله أنا رايح أكون معكم دائما في هاي المحاضرات، وشكرا جزيلا.
دكتور ماجد هذا من لطفك، أنا شاكر لك. أنا بإذن الله يعني في خلال أسبوعين يعني متوقع إن شاء الله أكون في فلسطين. يعني يسرني جدا إذا في محاضرات أو مناسبة نعطي للأطباء في فلسطين سواء كانوا ريزيدنتس أو غيرهم، أنا يعني على الرحب والسعة، وإذا في فرصة حتى نشوف مرضى أيضا طبعا يعني هذا الكلام يعني واجب، مش بس يعني يسرنا ذلك. فأنا يعني مستعدين، بس على الأغلب أكون معظم جون، يعني حوالي بتوقع 6 أو 7 جون لأول جولاي أكون في نابلس إن شاء الله رب العالمين.
جزاك الله خيرا.
وجزاكم شكرا لكم جميعا.
شكرا دكتور.
يعطيكم العافية.
الله.